All right, let's get it started. Good morning, good afternoon, and good evening, everyone. Thanks for joining this seminar and a panel discussion about COVID-19 modeling. I'm Mohammad Jalali. I go with MJ. I'm an assistant professor at Harvard Medical School, and I'm going to moderate the session today. So first of all, let me acknowledge that this has been a terrible pandemic. Too many people have already lost their lives. And I should also thank the many wonderful people in the healthcare, in hospitals who have been in the front line of the pandemic and addressing the issue. We are going to have several panelists talking about different projects today. Very excited to have an amazing group of panelists. And if you find anything interesting today, if you hear something that you feel like it's good to share with the rest of the world, please do that. Let us spread the word about the amazing work by the good member of the ST Society. These are the handles of the Twitter accounts. If you also have questions, this is one way to ask your question. You can go to menti.com, use that code. The link to go to the question platform is also going to be shared throughout the chat option. So if you are new to modeling, this is the best time to enter the field. A couple of years ago, we had to spend a couple of hours convincing policymakers why they should care about modeling. But it's a different year. It's a different time. Now you hear about models everywhere, from using the models in government decision making to news media coverage. And also we see some top medical journals who have traditionally been against models or not a big fan. Now they're publishing good modeling practices. So essentially models are helping in two ways. They're estimating the spread of the outbreak, and they're also helping to analyze understanding the effects or outcomes of different interventions, different scenarios in the upcoming weeks, months, or years. So I want to give a quick overview of the major modeling approaches that we have to set the stage for the presentations today. Essentially, there are two modeling approaches. One is forecasting statistical models, when people typically fit a line or curve to data and use regression or other sophisticated machine learning methods. One of the most famous examples is the model from IHME. They're not necessarily accounting for how transmission occurs, so they're not best options for long-term predictions, and they're not necessarily the best tools for understanding the efficacy of different interventions. On the other hand, we have mechanistic models where they are essentially reflecting the underlying transmission process. They're including important delays and nonlinear feedbacks, such as the more people become infected, the faster disease spreads. They're covering a wide range of modeling approaches. ST models are falling into this category. One of the famous models, not necessarily one of the best, but one of the ones that got a lot of attention in early days was the model from Imperial College London that is falling within this category. They're essentially used for forecasting not only short, but also long-term future transmission scenarios by changing assumptions around transmission, disease, and immunity. But there are also a lot of concerns along the way. So if you are new to this area of research, epidemics can essentially die away in two different ways. One is there are essentially no longer enough susceptible people to get infected, or something changes to slow down the transmission. This is the area where we design different scenarios and try to change different policy levers in the model and project the outcome of different policies. There are many unknowns here. The true number of infected people, the extent of protective immunity, among others. So that's why we use sensitivity analysis. And today you're going to hear about different types of sensitivity analysis. And it's a wonderful tool for us to test the robustness of findings to unknown parameters, the range of possibilities, uncertainty around different projections into the future. And one thing that I want to emphasize here is the confidence intervals that you see around projections in COVID dashboards or in different articles. They're not necessarily taking into account the so many different types of uncertainty that we're talking about, essentially uncertainty in the model structure. So Last but not least, this is an area that we need to continually work on and improve. We need to be innovative and importantly, build upon prior work. And essentially for doing that, we need to make sure that whatever we are building is fully transparent. In a recent analysis, we realized in a sample of 29 models, more than half of them did not even report their codes, or 45% did not share their longitudinal data. So we want to make sure that models that we are building are fully transparent. This is a very well-established standard in this system dynamics society. So today we are going to have a very nice set of presentations. Four great presenters are going to talk about a variety of topics, from discussing several outbreak response strategies to trajectories of the pandemic across different nations, the dynamics around vaccination and controlling the spread in universities. I should say we have a fairly diverse panel of experts with different expertise, but I also want to acknowledge two lack of diversities here. One is these are not presenting all types of modeling. We definitely have other modeling approaches, such as group building, community-based qualitative research. A lot of amazing work is being done by the member of the society. So I'm going to turn this lack of diversity into an opportunity and welcome researchers in that area of work. And hopefully the society will organize more events in the future. Another lack of diversity is, I think, very obvious and clear by this picture, and that is gender diversity. Hopefully we can address that in future events as well. All right, so last thing, there is a wonderful page in the System Dynamics Society's website. Please go there. This event is going to be recorded and shared. On that webpage, there are also other materials already available. So without further ado, let me invite the first speaker, Dr. Struben, to start his presentation.
Thank you. I just need to share my screen.
Mm-hmm.
So you first will need to stop sharing your screen. Okay, thank you. Right. So welcome everybody, and I'm excited to present my work on the coronavirus disease outbreak, simulation-based assessment of outbreak response and post-peak peak strategies, and I will provide a brief summary. There's a paper that's been published and that has all the details. Let me start by going back to the earlier period of the pandemic. Rapid early growth from the first case then identified, at least what we knew in the first months, this being December 31, 2019 in Wuhan, leading to, in a couple of weeks, confirmed case in Japan, Thailand, South Korea, Italy and the United States, to over 150,000 cases by mid-March and 1.25 million by April 6th. Over 65,000 reported deaths at that point, in total of 180 countries. And much uncertainty existed about the rate of transmission as well as the long-term impacts. Early estimates suggested that the coronavirus to be about 10 times deadlier than flu, yet there was still much uncertainty about the true infection fatality rate, the IFR, the death rate of the actual cases. And it's particularly hard to detect because of the large number of cases in this particular pandemic with mild and flu-like symptoms, making it hard to assess the actual number of affected cases, as well as because of the limited testing capability available in the beginning, and because of the endogenous factors such as hospital overload and affecting mortality risks. Nevertheless, the high death rate and the transmission characteristics suggested that early that a natural herd immunity strategy is unlikely to be feasible, and countries needed to respond forcefully. The global outbreak has spurred much research to better understand policy effectiveness, different contact reduction efforts, such as estimating the duration of infectivity or effectiveness of face masks, comparative effectiveness of closing restaurants, schools, business. And this is all very important and critical, but sole focus on such questions may lead policies to emphasize prioritization of efforts in the pursuit of an efficient approach, tending to a hesitancy to impose strict measures that control and confront the fundamental underlying dynamics of the pandemic. And so this paper's goal was, at that time in February, March, to address some of these dynamic questions that help guide decision makers towards longer-term, high-leverage strategies. And to illustrate this need, recognize the large variation in country-level interventions, as well as in the actual outbreak patterns. Here you can see comparatively cases in South Korea, Italy, and the United States, and all countries had in the first case within the same day, January 18 or 19, 2020. South Korea was much higher in reported cases in the beginning per capita, on a per capita basis, but also did much more testing. And while per capita testing of Italy and the US began to exceed that of South Korea by April, this occurred also under very much greater case counts. And the stars indicate the number of reported cases at which cumulative testing exceeded 2,500 per million. And it's much lower for South Korea, meaning that they were testing at higher relative rates early on. Variation can also be seen in social contact reductions, earlier but less forceful in South Korea than in the other countries. In the paper, I go much more in depth in sort of the variation in those strategies in those countries. I know that the large cross-country variation, and approaches is still very much the case a year later. Okay, so in this paper, I focus on the dynamics and interactions. How does the extent and timing of various interventions impact outbreak patterns? There's three main model components. The first is a classic SEIR, susceptible, exposed, but limited, infectious, infected, recovered, and then also deceased structure. So population move from left to right. They may also stay in the susceptible population bucket. And it includes the classic transmission parameters used in the epidemiological models, such as the incubation time that you can see here. In addition, social contexts that drive the infection, that's the positive feedback loop here, from infected population to infectious contacts to transmission. Social contexts themselves are endogenous, and they are driven by case testing and reporting, which increases the perceived outbreak, which leads to responses. Case testing itself is also endogenous in the model. In addition, I have a cross-sectional data set of 6 countries with diverse outbreak data, reported cases, reported deaths, testing, and social context, and calibrate the model to those cases, and then impose policy interventions to explore the effect and the dynamics of these policy interventions, individually and collectively. In terms of timing, it started around February, April 2020. Last data point used in the data is May 15, and the peer review process was April to September 2020. The model is fully reproducible, and the model and its data sets and scenarios are downloadable, and then you can replicate the calibration and the simulations and the experiments. I want to highlight a few aspects of the model very briefly and touch upon those. So first of all, the main point is that the infectious population in this model is disaggregated into mild, severe, early stage, and advanced cases. You can see that over here. So this box here provides more detail over there. This is important because it's the severe and advanced population that end up in hospital, and some of them die. Those ones are easier to detect, but these ones are very hard to detect, but they contribute very much to the transmission of the disease. And so separating that captures that uncertainty that we have around some of these transmission dynamics. This aggregation also highlights here, you can see stacked boxes, different status in terms of detection and confinement of the population in those different boxes. The model also is disaggregated into population segments, so you can capture heterogeneous social context across different geographies or between different socio-demographic segments. Then an aspect that is important to highlight in terms of social context. Social contexts are endogenous. They respond actually to confirmed cases. There are then social contexts that are driven through the exposed context. And the exposed population may reduce their context because undetected cases reduce context, either voluntarily or being urged by governments, social distancing, but also undetected cases being quarantined because they have been associated with detected cases through targeted efforts, that's home confinement. The infected population may reduce context in the same way, but also the positive tested population at hospitals or elsewhere can be isolated. as well as they can reduce their contacts voluntarily because they are sick and they stay at home because it's just unpleasant for them to get out on the streets. So these dynamics are in the model. The last aspect of the model I want to highlight is that the case testing itself, the testing capacity and utilization is endogenous, but also there's two different types of testing. One is reactive testing, that's symptoms based. People in hospitals or at home with symptoms, they can ask or be tested. But there's also proactive testing that goes through contact tracing and allows you to identify suspect cases and test those. This allows you to get to the mild cases. It's very costly in terms of that you identify a lot of negatives before you maybe identify some. It requires also capabilities to actually make this work. So these are the main components of the model. Let me now show you the cross-sectional, an overview of the cross-sectional calibration of the model for 6 countries. In the paper, I describe in more detail why these countries, but it's basically that their policies have very different, and you can see it also in the response, in the outbreak size. New reported cases vary differently across those countries, as well as their patterns over time. This is from 0 to 128. As I said, is from December 31st, 2019 to May 15, 2020. What you can see is the new reported cases, reported deaths, viral test performance, and social contact volume. The red are the dashed lines are the actual data, and the blue is the calibrated data. And the figure shows overall the calibrated simulation replicating a smooth path of the noisy data. For the calibration, I set the virus transmission parameters that for which we had at that point enough confidence. I set them to those estimates that other ones have done, for example, incubation time. In total, I estimated 22 parameters jointly in this one calibration. 11 of those vary by country. For example, contact reduction responsiveness is a policy that may vary by country, but a parameter like the fraction of the cases being severe rather than mild is estimated across all those different countries. The parameters overall are consistent with other findings and also consistent where we're not in other findings, consistent with what we would expect. For example, those who are actually exhibiting symptoms and get sick reduce their contacts by 67% based on this calibration. There's lagged responses from France to the outbreak, but there's a large contact reduction fraction once they get into response in France. And we've seen that in the real world. There was a very sharp confinement period in March 16 in France. Effective proactive testing only in South Korea during these earlier periods. In terms of confidence building, well, there's several parameters in terms of the actual cases very dependent. The estimated active cases vary a lot by when you change some of the parameters, but actual death is actually a very fairly robust focal variable, and that is the one that we will focus on. So even if you, for example, do a re-estimation with where you change the severe cases, the actual deaths remain fairly stable. Okay, so let me show you 3 experiments very briefly to give you an idea of what the kind of analysis I've been doing. And the first set of analysis focused on a baseline case, a calibrated simulation until May 15 with the data, then continuing until September 5, 2020 as an out-of-sample scenario. And that scenario assumes that the social contact reduction efforts remain constant from May 15 until all the way in the end. And that allows doing more controlled experimentation. And what you can see here as one such experiment is the different responses in terms of testing and the impacts for the various countries. And the graph shows the fraction of cases that we actually test. And if for the severe cases, you can see these ones over here for Korea, Italy, and the United States, we can see that South Korea is able was able to test, according to the simulation, a larger fraction of the severe cases. It's even stronger for the mild cases. Only South Korea is able to actually capture a reasonable fraction of the mild cases early on. And to a degree, this is actually consistent with a strategy that that South Korea deployed, really trying to build up contact tracing capability early on. However, the large gap is greatly expanded through positive feedback of case detection and social contact reduction. And you can see that on the right-hand side. As we get more confirmed cases, we respond to the outbreak. We reduce our social contact through a number of policies that reduces our transmission rate and that reduce our active cases. That occurs, but then there's also positive feedback. And as we get increase the confirmed cases, that allows us actually to implement those policies, but it also frees up testing capacity. And if you have the capabilities, allows you to go after mild cases, that allows you to test more cases, a larger fraction of the cases, do effective follow-up and further reduce the active cases by isolating those cases that you have detected. And so this is an important positive feedback that helped South Korea, and it worked the other direction for many of the other countries. And for example, further analysis shows that France was really only able to test the severe high-end cases, and therefore they only captured a small fraction of the cases, leading to less effectiveness to suppress social contacts of infected cases, leading you in turn to get further behind with your testing capacity. So that's the first main insight. Yeah.
Yeah, we should probably move to the second presentation. I'm sure you have a lot more to talk about. Hopefully we can come back to the rest of the presentation during the Q&A.
Absolutely. So this gives you an impression of the kind of experiments that we're doing. So let me just maybe summarize and provide some concluding notes. So analysis of the simulation experiments using a model with endogenous social context and testing approaches shows that slow, weak, and vacillating policy responses help explain the outbreak and the confinement failures. Unfortunately, 12 months after the first known outbreaks, such insights are still relevant right now where we are. And so we need to improve policy attention to dynamic and longer term thinking. Model analysis of this kind of models can be replicated, in particular this one, and allows you to do further this kind of analysis. So thank you very much for your attention.
Thank you very much. Hazhir, the floor is yours.
I'll stop sharing. That needs to happen. Yeah.
Oh, you're muted, Hazhir.
Okay, can you hear me now?
Yes.
Excellent. So thanks a lot to Jeroen for setting up this stage. It makes my work much easier. This is joint work with T.Y. Lim and Jonas Sterman. We have been working on this project since March, April, and it is still ongoing. The paper is under review, but we are continuously updating and recalibrating the model. So I'll share with you links if you're interested to see kind of the most recent projections. And to get us started, basically, the motivating puzzle for us is that we have one disease, but we have almost 2 orders of magnitude variance in the outcomes, and the key outcome of death per capita, for example. What you can see is ranges between 1 per million to 1,000 per million across different nations. So what explains these differences? It could be differences in demographics. We know age has a major impact on death rates. It might be differences in healthcare systems. It might be differences in surveillance systems. Maybe we are not actually seeing the true death rates. It might be differences in government responses or a plethora of other explanations. And try to understand this is important because that helps us also think about what policy levers there might be and what overall determines the impact of the pandemic. So we go through building a similar SEIR-based mechanism-based model. We know about all the limitations of the kind of plain vanilla SEIR model, no behavioral feedbacks that capture changes in risk perception and response, and doesn't. So we start adding these and looking at this at the scale of global pandemic across different nations. So we look at 91 nations, essentially any country that for which we have testing data, death and infection data over time. We estimate the model parameters capturing a variety of biological and behavioral response factors. It is a hierarchical Bayesian estimation framework which couples the parameters across different nations. So we have a parameter, for example, for basic reproduction number. That parameter has a copy for each country, but we are looking at it across, we are kind of getting them to be close to each other across countries. This aggregate at the level of hospitalization or not, whether people get tested or not, and then we look at the distribution of severity using a zero inflated Poisson distribution for the distribution of severity across people, which then determines whether somebody gets tested or not, whether somebody may be interested in getting tested or not, and whether they go to hospital or they may die. So all of those are kind of contingent on the severity levels, and we use an analytical formulation so that we don't need to disaggregate for different severity levels. Rather than that, we use a whole distributional analytical function to drive that. And then testing endogenously impacts who is detected, who goes to hospital. Hospital impacts death rates, and then risk of death impacts actions that people take to reduce contacts or governments take to bring down contacts. We fit the model to those 91 countries. Here are the larger countries. You can see death in red, infections in blue. You can see countries, these are results until end of October. As I said, we do calibrate the model regularly, so we have data until results until December 17 now on our website. And you can see countries like the US and Iran that go through 3 distinct waves that we capture in the model endogenously. You have countries like India that are just passing their first wave, and other places that are in the middle of their second wave when we had this calibration. Now, it is not enough to just show that fit to the data. What helps us build confidence in the results are a few additional tests. First is some out-of-sample predictions that estimate the models up to data up to August 10th and then predict until November 1st. They show reasonable overall fit for the longer term projections, but also with several significant deviations. You can see, for example, Italy here, we missed the timing of the second wave. India, we were too pessimistic about their response at the time by the data by July. The second way we build confidence in the model is we generate synthetic data using the model as a data generation engine, and then re-estimate the model using this new data. Now we know the parameters of the model, and we are able to recover all of the parameters and the confidence intervals pretty consistently. And third one, we go and collect data for prevalence tests that are done nationally across several countries. We compare those with the data what the model predicts. So, for example, for Belgium, there is seroprevalence data that estimated that around 5% of cases on April 2nd. Our model is the red one that shows about 4.5, and similarly for other countries. So overall, it has a pretty good fit with the data that shows we are capturing the true magnitude of epidemic while matching the data for the observed one. The observed ones are always very much lower than the true values. The black lines, the black dots are the observed reported cases. So what are some of the results? First, there is huge estimation of the true number of cases by about an order of magnitude, and about 40% underestimation of the death numbers globally. And we have estimates for each country. You can check those out in the data. But herd immunity is not yet close for the vast majority of countries. In fact, the time it takes to get to herd immunity are in the hundreds to thousands of days for most countries based on the current rates. So herd immunity is not even a viable pathway to think about. Second thing is that infection fatality rates that we estimate are consistent with the literature, around 0.5%, but very much dependent on age distribution in the country, and infection fatality rates have been going down significantly over time. Here are a sample of countries, partly because high-risk groups become more careful and they reduce their contacts significantly, partly because of hospital learning curves, and there might be other factors. Some parameters that we estimate for the overall epidemic, basic reproduction numbers that are in the 3.4 range, but with some significant variation across countries. About 50% of cases are asymptomatic, and infections of asymptomatic, they are less asymptomatic or less infective than symptomatic, about 30%. Impact of positive, if you're tested positive, you reduce your contacts significantly to about 14%. You can, of course, use this model for projections, and we do that. And looking forward, by the end of this winter, we actually estimate a significant number of countries to have major outbreaks that can raise the total case count by about double the current numbers, and up to 4 million deaths is our baseline projections. An interesting question that has been kind of in everybody's mind is how much of a trade-off do we have between economic costs and the public health costs of COVID? And a good proxy for economic costs is how much you reduce your contacts. So if you map the relationship between the reproduction number, which is essentially a proxy for how much interactions there are and infectious interactions there are, against daily deaths per million of the population, you look at the data, the surprising result is that there is no trade-off between the two. That is, essentially every country goes to reproduction number of around 1. Why? Because if it is above 1, the epidemic continues to grow exponentially. This means huge costs, huge death tolls around us, and that forces people to bring down their contacts. And if it goes below 1, death rates go down and people stop to care. So the equilibrium-ish or pseudo-equilibrium is a reproduction number of 1, which means every country is essentially doing the same thing in terms of how much contacts they allow to happen in the society, but they can get to this equilibrium at any level of infection rates. And that is the really interesting feature of this dynamic system, that you can have very different equilibria across countries with 2 orders of magnitude difference in death. And in fact, if you do a little bit more detailed study of this, you can see that the correlation between contact rates and death rates could even be negative. And this is what we find across 100 countries. And the reason is a mixture of low case numbers allowing for better contact reduction strategies like targeted interventions with contact tracing and quarantine. It makes planning easier. It improves the public trust that helps governments improve adherence. So we have all of this model available for anybody interested. On an online simulator, we have added a vaccination sector to the model that allows you to change and see how changes in responsiveness and vaccination can impact the forward-looking trajectory of the epidemic, as well as the backward. You can see the quality of the fit with data for different countries. And with that, I'll stop. Thank you.
Great. Thank you very much, Hazhir. Jack, it's your turn.
Thank you, MJ.
Excellent.
Okay. Well, you've just heard 2 wonderful presentations about very sophisticated work on COVID. I've done my own sort of homegrown model. This will look a little different from the others, although it's still an SEIR model. My subject is COVID dynamics only in the United States, 1 country. And the question I'm asking today is, will the vaccine save us? So before we address that question, I just want to give you a sense for what kind of model this is. I would characterize it as an exploratory model. I started developing it in March just so that I could better understand what seemed to be happening and maybe help some others to do the same, my friends, family, colleagues. This is only for the US, as I said. It's not even broken down by state. So it's a fairly simple model with an emphasis on understanding behavioral changes we've seen in society over this past year. So my purpose was not guidance for decision makers. I have no plans at present to publish this work. But I suppose that's allowed me a certain kind of freedom in developing the model. I do follow the studies and the latest data, and I think for any of you who doubted that system dynamics can be very evidence-based, all the presentations today should disabuse you of that idea. We all use data, and it's very important that we understand what's going on mechanically and that we also check our models against data. I adjust the model as needed, and sometimes, so there are both endogenous structures in the model and exogenous ones that I sometimes have to change to keep the model on track. Like the current surge is something that I did not anticipate, and although some saw it coming, you know, this is the end of the year holiday season, people are inside now, and that helps to explain the current surge. You know, I don't think anybody knew how big it was going to be. This is just the next in a series of slide decks I've been doing since March as my model has evolved. You can find the others at this, this Google Drive URL, and Carl Smith in Australia is the one who set this up. There's a lot of good material there. My model is located there too, the latest model. So let's just take a look at this model. It's a couple hundred equations in all. Down the center, you see the usual SEIR structure from susceptible to recovered or deceased. And you see the usual kinds of infection feedback loops as well. What I want to emphasize here is in yellow, a few areas where I was able to, with the data, check what the model was doing against actual evidence. So I have collected data, as the others have, on cases, on fatalities, on hospitalizations. And those data have sometimes forced me into adding certain structures to the model as time has gone along. So for example, this whole piece up here having to do with critical care capacity, ICUs, EMS and so forth, is something that I was forced into concluding must be dynamic over time. The critical care capacity was a problem, for example, in New York and New Jersey originally, and then that problem sort of takes care of itself over time, albeit with deadly consequences in the short term. But there's a sort of balancing loop that has to do with critical care capacity. The data forced me into that. Also, the data forced on mobility reduction and on unemployment, forced me into certain conclusions about how quickly the isolation response was occurring. And also about the idea of isolation fatigue, which is a phrase that I don't think was even in the vocabulary until this year. And so, you know, so that's one lesson, is that, you know, I sort of added loops and variables as I had to, guided by the data. So when my developing model would fail to reproduce history and the latest data, then I was forced to turn to, you know, what other variables are needed to make that happen. So this is very much in the tradition of iteration and evolution of models. In green here, we have a couple of areas in the model where I can do testing. I also at various times had things like contact tracing, but currently I'm focusing on vaccine effectiveness and reach or adoption. And also this issue of safe public behaviors as opposed to isolation. This is how do people behave in public with regard to masks and social distancing, as opposed to more basic mandates for isolation and people self-isolating. So there's that distinction in the model. And this piece is also exogenous. So what you'll see today is my testing these two green things. This is just so that you understand the model is, you know, we saw the first cases in February in the United States. The first death was February 29th as reported. And the model is able to reproduce cases and fatalities pretty well, not perfectly. I didn't pick up this second peak, which Hazhir showed us that he was able to pick up. So you know, that is to say that this is an imperfect model and doesn't have every twist that it might have. And so this is a full year from February 1st, 2020 to February 1st, 2021. I'm anticipating some fall off in, or a peak and then decline at some point in cases and fatalities, based on an assumption that our behavior sort of returns to normal after the holiday season. If I don't assume that, then these cases and deaths continue to go up. And we don't know yet how high this peak will be. It looks like it's still climbing at this point. And and it reflects a few months worth of bad behavior, starting at the end of October as we entered the holiday season, and even now as flights are booked for Christmas holiday as never before. Okay, so just a list of some discoveries along the way to give you an idea of you know, the learning that I've been able to gain and share with my friends and family. First of all is that, you know, comparing, looking at the other models that were available from Princeton, from Harvard, from Yale, you know, many of them lack endogenous social behavior, and so they can reliably project only about 1 month. And the modelers say, well, you can't possibly project past 1 month. Well, in system dynamics, we believe you can do better than that. That it is possible to find some rules of behavior that people follow, even when they're presented with newspaper articles that tell them how bad it is. They will still do these things because of social structures, because of norms and pressures that we can try to model. So other things about critical care shortages, as Hazhir talked about, the trade-off between safety and the economy is a false trade-off, something that I sort of discovered early on in my modeling. Other things, let me just focus on this one. It's been really hard to predict a couple of things. One is the demand for testing. And so in my model, I don't even try to do that. It's been so unpredictable. So I do that exogenously. And the other has been this end of year holiday effect that I mentioned, where I've come to the conclusion that that effect has reduced safe behavior for the last couple of months by about 30%, which is quite significant and has sent the basic reproduction number up above 1 and is responsible for this current surge. So on the vaccine, you know, I've concluded that it has to be both effective and widely adopted to significantly reduce the need for isolation and caution, but I want to say more about that right now. So is the vaccine a magic wand? I want to show you 4 scenarios around this question. So we're all aware that there are these 2-dose vaccines now available from Pfizer and Moderna, which are based on mRNA, and also a more conventional one from AstraZeneca. They have efficacy of 66 to 95%. There's a lot of confusion in the news about what this efficacy means, but it really, if you look at the documents, it has to do with different infection endpoints that are being measured. Nasal swab, blood test, symptoms, and those give you different numbers. So we're a little uncertain about the basic idea of efficacy, but if you think of it in the usual way, which is how effective is it at reducing transmission or further infection, it's somewhere maybe between 66 and 95%. In terms of how many people will end up getting vaccinated, Pew Research surveys tell us it's between 50 and 70%, maybe 72%. Maybe if there are requirements from employers that you get vaccinated or from airlines, that number could be even greater, but I'm going to look at 50 to 70%. Now, here's an interesting quote from Peggy Hamburg, who was the head of the Food and Drug Administration in the United States previously. She said, people have to understand that vaccines are not a magic wand. That is, we will still need to wear masks and do social distancing until the epidemic is over, she said. And she asked the question, will we comply? So that, when I read that, that was kind of shocking, because what if not a vaccine is a magic wand? You know, we hope that the vaccine is a magic wand, but, and I guess the key question here is this phrase, until the epidemic is over. What does that mean? You know, how many months or years will we have to wait until we consider the epidemic to be over, when we can no longer have to mask and social distance? So what I tested in my model were 4 different scenarios defined on how effective is the vaccine and how widely is it adopted. So the very best cases in which the vaccine is 95% effective is adopted 70% by June. and also assuming that post-holiday behavior is good and remains good, even when people get some confidence about the vaccine. The worst scenario is one in which the vaccine is less effective, there's less adoption, and then people start to get complacent and there's a decline in safe behavior from February to June, sort of a linear drop off in safe behavior. So this is what I find in terms of cumulative COVID fatalities with January of 2020 through January of 2022. Here is January of 20, this is where we are right now. And you see these 4 different scenarios resulting in different amounts of death. So, so the very best one is the blue line where we have the best effectiveness. That's a cumulative dead by January 2022 of 585,000, all the way to the worst one where you have unsafe behavior, lower adoption, less effectiveness, all within sort of plausible ranges. So this is my plausible worst case, you could say. It's not 2 million or 3 million dead, but it is 150,000 dead more than than I see in my best case. The things that make the most difference are the effectiveness of the vaccine between blue and red, the adoption between red and green, and then safety of public behavior between green and gray. So looking at other scenarios too, I've come to this conclusion that with lower vaccine effectiveness or adoption, more infections occur and isolation mandates would have to continue. In the more optimistic scenario, this blue scenario, isolation becomes mostly unnecessary and safe behavior less important. And we see that over here, where in the worst cases, you continue having to have something like 40 or 50% isolation mandates. And in the best case, it can come down to 15%. So that ultimately is the payoff, that we can drop our masks at a certain point eventually, if all of these good things are in place. So with that, I will just turn it over to Navid. Thanks very much.
Great, thank you very much, Jack. Navid, the floor is yours.
Okay. A few months after the outbreak or the pandemic started, people asked this very specific question that should universities open in fall 2020? And that was a challenging question, and it became even more important as we all lost our hope in summer weather that may help us, and it didn't help. So there was, we were dealing still with pandemic, and the question became more and more important. And universities took different approaches, but there was this common approach that, we should open, it's worth the risk. And, many articles came out, and you all know that what happened later, a few weeks later, many of the universities had to close and had no way other than closing to control the pandemic. And now when you look at the data, they have ended up with about 400,000 cases in universities. And that's very alarming. Could we do better back then? In early summer, I was involved in this project of developing a tool for universities to help develop model-based policies that help them to better manage their universities as affected by COVID-19. And we know in our university, we had meetings every week, and we work collaboratively with different modeling approaches. But the model that I concentrated was following this structure. It had this epidemiological sector that you saw in the previous presentation. So I was following the SEIR-like models that you have this basic physics of how infection transmit across the population. I also included the fact that, especially in college towns in the US, you have suddenly a huge flux of individuals that are coming to the college town at the beginning of the semester, and they are going to leave if the university closes early on or if the semester ends. So you have this huge flow of individuals that are coming to your university. Now there is this information about cases that are happening, and I add the behavioral sector to my model, because it turns out that it is important, and you saw in the previous presentations, that people react to the type of information that they receive about the cases that are going on. And these reactions can be changes in our behaviors. It can be changes in policies that universities in this case are implementing, and those policies can influence people's behavior too. And there can be early closure in this university cases, just to prevent catastrophic outcomes. And testing is very important, and testing can have different impacts in these contexts. I have these two specific effects that, with better testing, you can diagnose, and you can have more effective isolation and quarantine. Also, with better testing, you can better communicate about the status of the system in terms of number of cases that are emerging. If you don't do any testing, you don't know what's going on, and that's there is less to kind of leverage to control people's behavior. So I'm running this model. I ran the model back then for a hypothetical university that had 25,000 students and about 3,000 faculty and staff. And this was actually very similar to my home institution. And these were the outcomes, kind of a sample of outcomes that I was seeing. Daily confirmed cases, I was observing an early outbreak, and the university was planning to close at day 90. That's 3 months after opening. So we were planning for early closure, but still the cases were growing very fast based on the simulation. And although we were observing about half of the cases, still it was kind of troubling. And the fact that these number of cases are coming down is not because people have changed their behavior in the simulation model. It is because the model decides to shut down the university. It passes the predefined threshold for number of daily cases, which we set 100 at 100 based on interviews that we had with different people. And if you look at number of cases, this university of 25,000 individuals was ending with about 12,000 cumulative cases, which was considerable. Active cases follows kind of the same shape as daily cases. And another thing that I was calculating was probability of having at least one death. And that's very concerning. Students are coming to a university, and parents are trusting us. So it is very important to take care of them. And they are very young. We know that the risk is very low for them. But when you add all this population, you consider the number of cases that may happen in the universities, you actually get to something that is probably not worth it, comparing with the title of the article that you saw before. It is even worse if you include staff and faculty who are in older age categories. And this model was saying that in the base run, there is a good chance that there will be at least one death in the university. The reason that this pattern was stopping and we were able to control the model, as I said, the model was shutting down the university and active population was decreasing because they were leaving the college town. And that's the reason that number of susceptible were declining. Otherwise, it would have been increasing until taking the whole population. There were changes endogenously in the behavior in the model. As you see, contact rate was going down and kind of oscillating. And reproduction number, as you also saw in Hazhir's presentation, it was approaching to an equilibrium of 1 after a while. So I tested several policies in this model. This is my base run, and this is total cases that I see and probability of death that you saw in the previous slide. These are a sample of policies that I tested back then. There were more, but if we implement mask adoption, try to encourage people, about like 80% of people use masks, what would happen? Proactive testing was about kind of doing more tests, not just relying based on symptom testing, but kind of expanding tests. Risk communication was about communicating with people, trying to make them more responsive. And remote for high risk was about making sure that staff and faculty of older than 60 years old stay home and do their work from home. And when I implement those, the shape of daily cases change, but none of them are actually desired stage, especially if you look at the area under graph. Actually, we end up with still many cases. Some of the policies were better, but some of the policies were not actually better than the base run. If you look at risk communication, I was strangely getting worse result than base run. And when I thought about it, it made sense because with better risk communication, actually, the balancing loop that was becoming dominant was this communicating with people and keeping them in the school. In the baseground, my model was shutting off the university and sending students back home. So actually in risk communication, I was getting a worse result. On the death cases, the only thing that was making a difference was my policy number 4, that was keeping high-risk individuals at home. But still, in terms of students, it was a dangerous situation. Interestingly, when I added all policies together, I got way better results. And that's one of the things that, we who work in complex systems, we kind of understand this, because there are tipping points in these systems. And when you add 4 policies, you get more outcomes than, effect of each of those, sum of effect of each of those policies, kind of complex systems. But the outcome of this analysis was that, first of all, don't hold in-person classes, just go with remote, and it is not worth the risk. And the second was that if you want to open, early outbreak is very likely, and all policies should be carefully implemented, otherwise the results will be terrible. This is a post-analysis reflection. Now that I have data, this is how testing was implemented. It turned out that universities have different policies for testing. So we had a huge number of tests early on. And then, based on symptoms, we went through the semester. But again, toward the end, we had more frequent testing. And this was the cases that we saw in our university. So if I enter test as a data to my model, so I don't model the testing side, but enter a number of tests as an input to the model, and I simulate the model again, calibrated with the data, this is what I'm getting, and I estimate the parameters. So the overall trend is the same, and there are interesting things that I find from this analysis. One question was that what was the initial number of cases? How many students brought these cases? And my model was saying that about 25 students initially had the virus when they entered the college. I can estimate number of cases, active cases, and total cases, including the ones that they missed. And finally, one of the things that was interesting was that even though we started with about maybe 25 students, but the R0 was huge. And that's probably because of all these gatherings that happened early on in the semester, and that may kind of super spreader may contribute to very fast early growth in the disease in universities, which is a different context than other situations. So I just want to say that this was one analysis about universities, but there have been so many system dynamics for projects about COVID-19 all around the world. And I've been kind of following these studies in different parts of Europe. I've seen in Turkey, in Netherlands, in Ireland, in Australia, in Japan, all over the world have been studying this, and they are very interesting. And one of the things that I've also seen, and those things may not happen in Google Scholar, are all those community engagements that have been happening, and people have been writing kind of diaries and kind of talking to the public to make impact. And so when I want to reflect on what is going on in the situation of COVID-19, I would say that this problem has been so complex that needed including communities, needed including data, and it needed having models that address behavioral challenges that we see and they affect the transmission of the disease. Thank you.
Excellent. Thank you, everyone, for all of the interesting presentations. Let's switch to questions. Before going over questions, let me tell that we already received so many questions. We already have 37 questions. There's no way that we can address them all today. So please keep the conversation after the event. Contact any of the presenters, ask your questions directly from them. We are going to keep all the participants muted just because we just don't have time for that and answer the questions on the platform. And with that, let me share my screen. And I wanted to start with the most voted question, but let me violate democracy rules and start with my favorite question, which is, what is a good general definition of useful? And I also appreciate if panelists can keep their answers short so that we can answer more questions. Anyone wants to go on that?
I'll take a whack at it. So you know, these models looked very different from one another, and I think that's because they had different purposes. And so useful has to be defined relative to the purpose. My purpose was not to try to reach decision makers, but only really for myself and the people that I know. So it was a model for learning as opposed to a model for decision making. For that, you don't necessarily have to have confidence intervals. You don't necessarily have to have operational details. So useful, I think, is context dependent. And maybe I'll just leave it there.
All right. Jeroen?
So I agree with the context dependence, but it's a fair question to ask given the panel topic. There's a few things. I think one is what we have, the job is we have as modelers and of dynamic issues that can bring up issues that allow, bring insights that some other models cannot, is to have robust models that are for the right reason. But again, it depends on the purpose. That Jack said, he used it for insights. If you want to get part of the conversation, then where it's sort of the models are used for policy, you need to have a robust model, and it's robust for the right reason. It also needs to bring attention to the high leverage insight. So what's so important? Why is it so important to act early? Or what's this false trade-off? And to really have a very crisp, added value to the existing discussion. That's a key point, I think, to highlight. There's many, so I think these are the first. We can get maybe to some other points later.
Excellent. All right, so let's go to the top question. Why did most models of epidemiologists fail to forecast the future trends? And I don't think that this is limited to epidemiologists. This is probably the same issue with ST models as well.
I will have to take a crack at that. I think, first of all, fail or not fail is not an absolute term. So you have to see what is your benchmark against which you are measuring any model. And in the general case, I think the long-term trajectory of these epidemic models usually fail to be easy to predict because the behavioral responses that change the infectivity and transmission rates are not fully predictable. Now, the models that do have endogenous behavioral responses do a better job, and I think that's what we see across all of the models that we saw today, that allow you to project for a few months ahead with reasonable success. But whether against some external benchmark in epidemiology models, these are really good or not, is a comparison that I have not seen done. I think from what I have seen in typical epi models, the fully endogenous behavioral response is not a common formulation, and as such, you may be missing an important lever for improving predictions.
Great. So the next question can be addressed by all of you. And I know this is a tricky question, but if you want to address this in 15 seconds, only mentioning the most uncertain parameter in your model, that would be great.
Sure. Very briefly, one key parameter that is very uncertain is in my case, is the fraction of cases severe, which channels infected population either to more mild or severe cases. That leads to different actual cases and much variation in actually the ratio between the actual and the reported cases. But the good thing is it does not have huge implications for the actual versus the reported deaths, which is then a key, which I use as a key parameter. There's much more to say about that, but this is what I'll leave it.
So, one thing I would have is the behavioral response parameters that we estimate for each country. They make a big difference for the long-term projections. We do estimate the uncertainty in those, but they conflate the uncertainty in the parameter and the uncertainty in the randomness in the world, such as Christmas, that changes behaviors, not endogenously because of the risk perception, but because of other things. And that conflation makes predictions even harder because we don't have predefined Christmas parameters for various model responses for different countries.
Great. Anyone else?
Yeah, I agree that this question of behavioral response is the most uncertain thing. And we see in the social mobility data that that even now when people are getting together when they shouldn't be perhaps, and not distancing the way they should be, there's still a pretty significant amount of isolation overall, of people driving less, of people shopping less. So that's been something that I've struggled with, as it seems to be two different kinds of behavior that we're trying to model.
Maybe very briefly, but that's precisely where you then can do experiments and to sort of look at responsiveness to, you know, in relation to that uncertainty, and think through different scenarios.
Okay, great. So let's move to the next question. I know Hazhir wanted to address this one. If anyone else wants to go after Hazhir, please.
So quickly, essentially what we find is that there is no trade-off. And if anything, there might be a positive relationship between the economic outcomes and the health outcomes, because if you can keep your case loads low, you do a much better job having targeted interventions and keeping your population essentially follow the right practices and keep the social capital high. So this is very kind of analytical, equilibrium-based idea. So you don't, this is not hand-waving. You can actually just write equations and prove that this is the case for an epidemic that is exposed to behavioral responses to risk. And I think it's a huge insight for policymakers to consider seriously.
Okay, great. Does anyone else want to answer this one? Jeroen, Navid? Okay, well, let's go to next question. How do you test and evaluate your projections? This was something that was discussed in the presentations, but if you feel like you want to add anything else, otherwise we can move to the next question.
Well, I just want to be clear that my projections have changed over time. From the, and this is why I've had so many of these slide decks, is that they, in part, that we have learned things as we've gone along. This is a very unusual situation, I have to say, in which we're trying to model real time. This is the reason that it's been hard for everybody to predict, even when we have our good feedback loops in there. Things like the end of year holiday effect, the magnitude of which is so hard to predict. So usually we're looking a little bit more in retrospect, and then before we look out into the future. So this is not just your typical SEIR infectious disease situation. It is something different.
And one minor thing that I add is the kind of the practice that Jack highlighted of recording your work from the past really helps you see what the discrepancies are 2-3 months later. And that is a very good way for ourselves to learn about what is missing in our models. You can very quickly get used to seeing the current quality of fit to the past data and forget about how bad the model might have been looking ahead. And those type of out of sample predictions are really valuable.
Jeroen,
yeah. So one thing that I also noticed is that I started out with modeling more at a regional level. So you think continents, and that made it very hard to get reliable prediction because there was so much, country level policies going on, and you can even think that, in the United States, and Jack probably has also played with that sort of there's a huge amount of different insights you get when you model at the regional versus the aggregate level. So that's one important sort of way to get different projections in this case, to look at sort of the level of policy where the policies are taking place.
Great. Navid?
I just want to add something here that there have been some discussions about why models fail to forecast the future, specifically in this in the case of COVID-19 and similar questions. First of all, many of the models that have been developed have been for nowcasting, kind of estimating number of cases, and some of the models have been for policy tests, and they are still relevant. But if the model is trying to address projection, estimating number of cases, there are a few things that we should consider. One is that the model itself is very important. So what I see, and I think Jack mentioned before, in many models that have been published, they are missing important behavioral feedback loops. That's a very important barrier for a good projection. And the second thing is that model parameters are important, and we should kind of estimate them. And the dilemma is that, before a feedback loop becomes dominant, it is very hard to estimate parameters that are related to that feedback loop. For example, we know that people, in lockdown, after a while, they will become frustrated and they want to go out. But if that event hasn't happened yet, it is very hard to estimate parameters of that feedback loop, to know what is the threshold at which people will become tired. So there's this puzzle there that you want to calibrate a feedback loop that we haven't had experienced that yet. You may use data from other countries, with some tweaks, but still, cultures are different, contexts are different. So it becomes very challenging. And that's one of the huge barriers for having good projection. But that's also something real that we should consider what's happening.
Good point. Because
there's one point that MJ is very important, and that's about we want to fix the society. So if our model is projecting something bad, so if my model projects that something bad is happening in universities, if I've done a good job, actually I should make the society move in a direction that my prediction becomes wrong, right? So I should have a good impact, so we move in the correct direction. That doesn't mean that my model was bad, but I actually did a good impact on the society to move it in the correct direction.
Great, because there was a mention of epidemiologists. Let me go to one of the most recent questions about that. I think it's a fair question, an interesting one. If anyone consulted with epidemiologists in building your model?
So I can add that the group that I was involved in this specific project, we're a group of about 20 people that maybe like 1/4 were epidemiologists, and we had people from physics department, from math department that do kind of biomedical modeling, and we have from operations research and all those things. So there have been kind of close interactions, and that has helped.
Well, there's a large body of work within and outside system dynamics that is really built on the history of epidemiological work. So that knowledge we could rely on. During the modeling, not, except for that what I just mentioned. But then after modeling, I got engaged in the RAMP network, which is a website that is, the goal is to bring modeling expertise from a diverse range of disciplines to support pandemic modeling community. And the idea is to invite to contributions by posting and discussing existing papers, and to have this kind of expert community level of engagement, and to bring papers to the front that are useful for this. And so has been an interesting effort, but not to develop the modeling itself.
Good. The answer for me is no, but I thought it was wonderful that so many great studies and modeling projects were posted in the pre-publication MED archive, and I gained a lot from reading those. And I consider myself an honorary epidemiologist anyway, having worked for a long time in public health. Just kidding.
So I would quickly add that I think the models are making an impact through the conversations within the policy circles for sure. What a specific model is being used for what a specific decision is a little bit of a harder question. You need to be part of those conversations to know. But I think the work that Navid and I have been doing, partly related to Iran, we have written articles on that in Iranian newspapers that we know have been picked up by policymakers and have potentially had some impact on some recent lockdowns that they decided to implement and so on. So I think the impact is there, but making the one-on-one connection is a little bit harder unless a model is specifically used for specific policy questions. And some of that has happened in the case of models for COVID as well, not the models we presented today, but I think more generally there definitely are.
But I just quickly want to highlight that it is a very important question because we need to all do our best to connect with where, as close as possible to the policymakers, and not surprisingly, epidemiologists sort of, are directly on these kind of decision tables. So it's very important to do more efforts to connect directly with that community in these kind of situations.
I also want to add that in order to make a good impact, you have to talk to policymakers, and you have to publish in venues that they read, like newspaper. But also, it is very important to have an impact on the society. So people who are living there, if they don't want to use masks, then even policymakers trying to encourage them, that won't be effective enough. In vaccines, we will have the same problems. So at the end, we should find ways to talk to ordinary people and kind of people who are at the front line, and that comes from community engagement, writing for them, and doing different sorts of interventions in the society.
Great. And that is definitely one of the areas that group model building and community-based research can definitely help out engaging more stakeholders. All right, let me go to one of the very important questions among the recent questions. So it turns out that SD models are big comparing to simple epidemiologist models. So what is the benefit of that? And then how do you justify that these are?
I'm not sure if this is a generally correct characterization. So you find a lot of agent-based models used by epidemiologists that are much more complex than what you saw today in terms of the number of variables and so on. In terms of feedback richness, probably the type of models you saw today are among the most feedback-rich models you will find in this space. And the justification is all about what you really need to include in a model for the purpose at hand. And as Jack highlighted, the data is essentially driving us to add components. I hate to add new components to the model, but when the model cannot really correspond to the phenomenon, then I have to add the mechanism. So learning curves for death rates over time, changing death, infection fatality rates, we didn't have it in our model. We added it because the data forced us. Adherence fatigue, we didn't have in our model. We had to add it because the data forced us. We changed our response function a couple of times, again, because the data forced us. So the point is, this is a conversation between data and the modeler, and you add the minimum that you need to capture the phenomenon. And I don't think the justification is in that. There is not any general justification.
Yeah, and some of the models also have very high detail complexity, right? So some of these Oxford models that are used in policymaking have a sort of a simulated small United Kingdom population of 30,000 agents, and so that requires a lot of assumptions behind. But I think it is a good point as part of the efforts that we have. I mean, this is not about one. It's sort of as part of the efforts that we have is if you have fundamental insights using one or two loops, and to get that more simplified model out there is very valuable as part of the project, but you still need the bigger models, as Hazhir and Jack also highlighted, to get, as you are forced to it by the data.
That's a great point. There's a specific question about your project, the detection of cases. And then we can go to the most voted questions after this one.
For sure, there is a balancing feedback loop. So in one of the simulation that I didn't show is where I look at resurgence dynamics, and so this is one of the scenarios where you where it's very interesting, where you can see the oscillatory behavior. As we get more and more, as the active cases go down, we detect more cases, and it allows us to be more careful, and that reduces then over time the active cases, and then over time we become less and less careful, and then that says emotional oscillation. And what's interesting here is that the proactive approaches can really suppress that oscillation, and that's an important dynamic. There's more research to be done. But that's an interesting question around, so what kind of policies can then suppress this kind of oscillation that you don't go back all the way, which we see in most countries right now.
So for the next question, the order just changed? Okay. Anybody wants to address this one?
So this is actually the initial purpose of our model, was exactly addressing this question. That is, the cases are significantly undercounted. Can we estimate that undercount? And to do that, you really need to think about different levels of severity. People with different levels of severity will have different propensity to seek testing. And then there is demand for testing from people who don't have COVID. And then you have limited test capacity allocated between these. You have to actually model all of those. And if you do that for a single country or a single region, it is very hard because you have too many degrees of freedom. So you can fit the model very well, but it is not necessarily getting to the core dynamics. So that's why we needed the kind of multi-country Bayesian hierarchical structure, so that we kind of learn from different countries in terms of those demand functions for testing and the distribution of symptoms, and then be able to say something meaningful about all the countries. And I think that was the purpose for that specific question. Whether it is generally something you have to have or not, I'm not sure. We have built smaller models that don't have those features, and they do the job well for the other purposes, I think. Yeah.
Okay, so the next, Navid, did you want to add anything to that?
No, I think Hazhir was.
Okay. So the next question, you already addressed the main part of the question, but I like the angle of transparency and documentation. Would you like to share anything about that?
Did you?
Well, this has been my most transparent model ever, I guess, in the sense that it is, from the beginning, has been for the public, and with no intention of more than that. So, but I wasn't approaching policymakers. I was approaching my friends, and this was sort of in line. It's different than what I normally do as a consultant. It was more in line with what Jay Forster used to want to do with his books. You know, reach the people so that they could make up their own minds.
There is often this misperception of trade-off between urgency at the early stage of the pandemic and producing the model, publishing the result, and transparency, documenting, sharing all of the details of the model. But we discussed this at the conference, International System Dynamics Conference, that there is no such trade-off. And from day one, we should be fully transparent and open about what goes into the model, what the structure, what assumption we have had in terms of building, analyzing, and reporting all the way. Is there anything around that? I see Hazhir has just unmuted.
So I would say that transparency is definitely a must. I have really benefited from others who have been transparent about their work. I'm right now building on some vaccination models that another team has worked, and they have been very clean, and that has helped me hugely. And I hope others can use my work and build on that. But that is not the same thing as communicating with public or policymakers. There is a small community of people who may consume models and look for transparency. It has to be there, but the communication with public needs other legs to stand on. And in our case, we have worked with MIT's media relations folks to write blog posts, to push the work into the news sources, and that has worked well. In collaboration with Navid and some other folks, we have written op-eds for Iranian newspapers that have been impactful. I have been working on kind of thinking about analogies that simplify the core dynamics into something very simple to communicate. That I think is very important. These models are very complicated. If you have clean analogies, they can make a big difference in making them consumable. So those are the types of things that are needed. And of course, there are others beyond this.
Yeah, I think this is a whole short-term and long-term sort of portfolio of projects that require this. I think the flight simulators are very powerful in doing this. I built an early version of the model into a flight simulator, and it was fairly well used. But I think the fantastic work in Climate Interactive shows that it's really you need a much more sort of broader process around this to really have it used as an impact and not just producing individual insights that do not really accumulate across different people. And so there's huge leverage there, but I think there's also work needed, and that we need to figure out sort of how we can do that. And keep publishing is also important. So there's a whole range of efforts needed there to do this. But transparency is, of course, a must to get back to that first part of the question.
Great. So we have less than 3 minutes to go, and I want to make sure I give 1 minute to Rebecca at the end. Let's go to the next question, and this is let's just start with Jack.
Right, the efficiency of vaccination. Well, I said a little bit about this. There is, in the press at least, been a lot of confusion about what is meant by vaccination effectiveness and distinctions between immunity at the humoral or the bloodstream level as opposed to the nasal mucosa. And is it possible that the vaccination could be effective for one but not effective for the other? And but as I read the FDA documents, the Pfizer BioNTech vaccine, at least, is very highly effective for blocking infection, and it's also quite effective for reducing severity. So I have modeled it. I had tried a couple of things, but I'm currently modeling it as just one thing, which is the ability to block further transmission, to block further the probability of infection. So I'm modeling it very simply. We may discover that it's something more complex than that, but for now, I'm trying the simple approach.
So I would, I think the two dimensions that Jack highlighted are the key, and probably a third dimension may exist that is about blocking transmission to others. And so those three dimensions might be how you model it. There are also dimensions on which you may prioritize vaccination. So it might be related to how much people are at risk of death, the IFR, infection fatality rates per individuals, the contact rates that individuals have, and how responsive to risk they are. And this is a very important space because the current policy is essentially focused on IFR as the first determinant, and then potentially on contact as second. And some of the results we are getting very recently is that the optimal is just the reverse. That is, starting with responsiveness to risk is the biggest determinant of the effectiveness of vaccine.
Okay, so this is probably the last question. How can we deal with the problem that policymakers are typically not able to assess model quality? Tough one. Anybody?
Well, it's partly their problem, but you have to be really good at making sure you have done the best that you can. And I think with this speed that things are going with the COVID situation, there is really not even the peer review process to do the checking of the work. So there is a lot of responsibility on us as modelers to do the best that we can, and then put it out there with full transparency, and then hope that kind of the system overall moves towards finding the better work.
And I like to add that replication is also another thing that all researchers can do. If we're making models transparent, we should replicate prior model just to verify them and learn from them and expand and build upon them. So I think that's also another important, other than transparency, we should focus on replication of prior research as well. All right. This is the end of the session from my end. I very much appreciate the time of all of the panelists and everyone who attended the session today. I hope this was an interesting session for you all. If you are entering this holiday season, I hope you have a wonderful holiday season. And if you are celebrating Merry Christmas, I want to give a few seconds to Rebecca to conclude. Are you muted?
Can you hear me now?
Yes.
Okay, thank you, MJ. I want to thank you, Navid, Hazhir, Jeroen, and Jack for a very informative session, and welcome you all to join us for future seminars, which will be happening next year Also want to point out that we're in the renewal season right now, and one of the major benefits of membership is free access to all seminars. This was special because we have a commitment to allowing free access to COVID seminars, but the remainder of our seminar series are a member benefit. So we hope that you'll join us for that. And we also—
Are you muted again?
Rebecca, you got muted somehow.
Yeah, sorry, the mute button and the other button are doing the same thing for me. So I'm back. So the other thing to let you know is to save the date for the International System Dynamics Conference, which is going to be on July 26th through 30th. It will be primarily online. We hope to have some events happening in Chicago, Illinois as well. So we hope you'll join us for that as well. And you can go to our website in order to get more information about both membership and the conference. Thank you, everyone.
Thank you.